I'll give a brief talk on the initiation and implementation of a tele-rehab facility at UAB, which will extend to the state of Alabama so that it's available to everybody. I have no conflicts of interest. This project was funded originally by a UAB HSF grant, and right now it's a clinical standalone program. So as you're all aware, COPD is the third leading cause of mortality in the United States. There's about 24 million people in the United States, half of whom remain undiagnosed. The prevalence is about 6 to 8% in the country. And there's about 10.3 million physician visits, a number of ER visits, and a high number of mortality. Predominantly, COPD is thought of as a disease of the elderly, but that's not necessarily true. It's mostly in the middle age. Half the people report an inability to work. Half report an inability even to do basic household chores. Not surprisingly, it's associated with significant healthcare costs, approximately $50 to $65 billion per year in the United States. And most of the healthcare costs are related to acute exacerbations. So this pie diagram shows that about 2/3 of the expenditure is related to hospitalizations, and a small number actually goes to the other kinds of expenditures. If you look at the trends for hospitalizations nationwide due to many chronic diseases, you'll see that the hospitalizations due to myocardial infarction and CHF are actually going down, whereas the hospitalizations for COPD have stayed steady. Now, this may be relatively good news, but the unfortunate fact is the cost of each hospitalization has been consistently rising over the years. So this has led CMS to look at these costs carefully. And there's been a number of studies looking at the hospital readmission rates and the number of hospitalizations. We all know that these patients are very vulnerable to a readmission within the first 30 days of hospitalization. This diagram actually shows that within 30 days, 20% of patients, or 1 in 5, get readmitted. This is all-cost readmission. If somebody has a fall in the bathroom and comes back, that's counted as a readmission. But for CMS purposes, it all counts as the same. And you'll also see that the most vulnerable period is within the first 7 days. 1/3 of the 30-day readmissions happen within the first 7 days. 2/3 happen within the first 2 weeks. So this tells us that there is a trend toward there's probably benefit in early action rather than waiting too long. CMS looked at readmission rates throughout the country, and they saw that there was wide disparities in the readmission rates around the country. So this is like a heat map. And they said, for right or wrong, they said, well, the care delivery is very heterogeneous throughout the country, so we need to do something to standardize care and reduce readmissions. It's not as simple as many of us in practice know, but CMS seems to think, as long as you homogenize the process, things ought to be better. So we tried that. We had a multidisciplinary team of pulmonologists, hospitalists, primary care physicians, nurse practitioners, nurses. So what we did was we enrolled patients we actually signed up for what was called the Bundle Payment Care Initiative. So we were on the hook for 90 days where if the way CMS did this was we entered into a partnership, and if we saved costs for CMS more than 3% of historic costs for 30 days, for 90 days, then we would get to keep some of the money. If we saved less than 3%, then we would have to pay a penalty. So the way we did this was once a patient was admitted with a COPD hospitalization, we would enroll them in this program. We would see if they had any social needs. We would standardize their transition of care. We would consult a social worker to get them the medicines they needed. Active smokers would get smoking cessation counseling. We would call them every day for 2 weeks and then have them see one of the pulmonologists or the nurse practitioner in the clinic within 2 weeks, and then call them every week for a month, twice weekly for the next month, and then at the end of the 90-day visit. And we'd also refer them to palliative care, pulmonary rehab, get them their flu shots, their pneumonia shots, and do all that. So there was a lot of work. We did save some money. We saved about 4.3% money to CMS, but we also incurred way more costs to the hospital than that. So basically, we transferred costs from CMS to our own on ourselves. The readmissions went down from 18% traditionally at UAB to 16%. Maybe this study was underpowered. This was all in comparison with historic controls. It was probably underpowered, but also there was no definite improvement seen. So why is that? So it looks like, even though social factors are important, patients' living situations are important, transition of care is important, we don't really have any great medicines that target readmissions. Now, if you look at exacerbations themselves, which are actually much easier to treat than a hospital admission in some sense, the leftmost column shows that if you use any of the long-acting controller inhalers, like inhaled corticosteroids, LAMAs or LABAs, the rate of exacerbation goes down by about 20 to 25% at most. no more than that. If you combine, in the second column, you'll see that if you combine a second controller, it makes no difference. It probably improves outcomes by about 2 to 3% at most. So again, a plateau of 25%. If you add three controller inhalers, again, the reduction in readmission is 25%. So it looks like we reach a plateau no matter how many inhalers you keep adding. So pulmonary medicines are limited in what they can achieve in terms of reducing readmission rates or even exacerbation rates. On the other hand, this Cochrane meta-analysis showed that people who go to pulmonary rehab and exercise, their exacerbation rate goes down by 78%. So that's like the magic bullet that none of the medicines can achieve, but again with the caveat that patients have to exercise to be able to achieve the benefits of exercise. So what does exercise have to do with COPD or COPD exacerbations and hospitalizations? Turns out a lot. Once you get an exacerbation, it's frequently seen that a lot of patients have skeletal muscle dysfunction. Now, there are a variety of reasons for that. It could be because they get steroids at very high doses in the hospital. It could be because they have nutritional depletion, reduced physical activity and deconditioning. But I think many of us have observed in clinical care that this weakness is on day one. It's not because they were in the hospital for a week and got deconditioned. So there's something more going on. It also is probably because of low oxygen and high carbon dioxide, both of which affect skeletal muscle function. It also could be due to reduced anabolic hormones. We know that under stress, a lot of us make a lot less anabolic hormones than if you're not under stress. Oxidative stress and systemic inflammation are also high during exacerbations. And probably the most accepted theory is that systemic inflammation and oxidative stress are the main culprits in causing skeletal muscle dysfunction. So the graphs on the right show that this is data from multiple studies, show that if you have COPD, you have a much higher level of baseline systemic inflammation compared to age and sex matched controls. But where's this inflammation coming from? There's about 3 studies which have looked at correlations between pulmonary inflammation and systemic inflammation, and the correlations are either extremely weak or completely non-existent, even during acute exacerbation. So it looks like even during an exacerbation, if you pick them within the first 36 to 48 hours, the correlation between pulmonary inflammation and systemic inflammation is very weak or not existent. So where exactly is this inflammation coming from? Regardless of where it's coming from, once you get systemic inflammation, the inflammation will not evaporate away. It's going to go back into the lungs and cause a cycle of damage. So there's something else we need to do about this. One of the hypotheses we have is that based on the previous slide I showed you about rehab working, probably when you get an acute exacerbation, you get inflammation in the lungs, which we know happens. Probably it switches on some signals in the muscles which are pro-inflammatory, and the muscles act as a reservoir of inflammation which keeps this cycle going. So based on the previous 2 slides I showed you, maybe the target should not be the lungs primarily. Maybe we need to target the muscles because we know they work, but how, we're not sure. Probably because of reducing muscle inflammation and hence systemic inflammation. So breaking the circuit at another place might be a way to go. That said, there are many barriers to going to exercise and getting rehab therapy. In 2013, we looked at our own data from the last 12 years of collection worth of data. And this is just for 2013. We looked at the data and found that only 1 in 5 people who were eligible for rehab were actually enrolled in Spain rehab at UAB. And there are many reasons for this, one of them being a significant distance from home and rehab centers. Many people have a lack of transportation. Some people can't even afford a $10 or $15 copay. There's limited parking, poor socioeconomic status, especially in this state, inertia, which most of us suffer from, and then there's a big dropout rate even after they enroll. So they don't really get the benefits of rehab. Another thing that's a problem in our state is that there's only 4 certified pulmonary rehab centers. And we are the number 2 state in terms of prevalence for COPD, but we only have 4 centers. And most of them are concentrated in metropolitan areas. So if you're in rural Alabama, you really are in the middle of nowhere with no access to rehab. So what we did was, this was as part of a HSF grant originally for 2 years, and then now it's a clinical program. What we did was we tried improving access to pulmonary rehab starting on day 1 of hospitalization. As soon as a patient got admitted, we would get an alert. We would go to the patient's room and try and enroll them and see if they're interested in rehab. We don't want to force anybody to exercise. That's really tough. So we would first inquire about whether they had access to rehab anywhere close to home, within 15 to 20 miles of home. Many of them did not. Then we would ask them whether they would be interested in enrolling in this program. This was a 2-pronged strategy. We would try and prevent deconditioning by using neuromuscular electrical stimulators to their quadriceps both thighs for 30 minutes each day while they were in the hospital, and this would be continued for 2 weeks. They would take the devices home, do that for 2 weeks, and then come back in 2 weeks to enroll in the remote rehab program. And I'll describe the remote rehab program in a second. So this is a timeline. So once they came back to the clinic, we would give them a smartphone, and it had, initially we started with Skype. I'm not supposed to reveal this because we were told it's very HIPAA compliant. Turns out it's probably not. Now we have a UAB proprietary software which is very HIPAA compliant. So we pretty much do FaceTime with them 3 times a week for 30 minutes, try and mimic all the exercises in pulmonary rehab. Aerobic exercises, some people are not able to do much. They're probably in the territory of physical therapy and not really rehab, but sometimes all they do is sit in a chair and do stomping movements. And then we had one person who had a home gym with mirrors on all 4 walls, with treadmills and ellipticals and bikes, and we had him exercise there. And people graduate. Sometimes they start off really poor, and sometimes we have them exercising at their local gyms with the phone in their hands while we are watching them and they're watching us. So we had truck drivers driving in Florida, and during a pit stop, Greg Sanders, our exercise physiologist, would chase them down and say, hey, when you take a break for coffee, how about you exercise for 30 minutes? So all that has led to some good results, which I'll show you in a little bit. So this is how we started. When we first started, we thought we should monitor their electrical signals, their physiological signals. We started with this, the one in the right, in the middle bottom. It's a bioharness device. You basically wear it around your chest. It gives us EKG signals, respiratory rate, and tidal volume signals, really good signals to continuously monitor them from a safety as well as a curiosity point of view. But the problem we soon figured was it would consume a lot of data. It would also consume a lot of charge on their phones, and our patients would never charge their phones. We would call them, and we pretty much had to wake them up to charge their phones. Also, some people would wear it around their neck, so it didn't really work. So we decided we had to change track a little bit, so we went to some basic, so right now, after multiple experiments, all we're doing now is giving them a pulse oximeter, which gives us the heart rate as well as the O2 sats, and we give them a blood pressure cuff so they can tell us their blood pressure before and after exercise and maybe in between if needed, and a smartphone with the app on it. That's all we're using right now, so we don't need anything more. And the data plan is free for the patient, so it's an advantage. So this is again a summary of what we do. So on the left-hand side, we do neuromuscular stimulation for 30 minutes, both quads, 10 to 14 days. Usually we ask them to increase the amperage as tolerated up to 50 amps. 50 amps is quite a lot. It can make your muscle visibly contract. There are some people who used only 5 or 6 amps, mostly a tingling of their skin, I think, but they still used it. Not everybody signed up for the neuromuscular stimulation. About half of them did, half of them did not. Many people are queasy about electrically stimulating their legs. One of the big side effects, or rather one of the curiosities that I learned during this process was NMES is interesting because the brain does not send signals to the muscles to contract. It's an external stimulator for the muscles to contract, so it can be a funny feeling that way too. And then we had patients do remote rehab 3 times a week for 30 minutes each day. And this included, like I said, aerobic exercises, very minimal or how much ever tolerated. And then we gave them a TheraBand to use their own body to do strength training. And then we also taught them pursed lip breathing, diaphragmatic training. Some patients who were willing, we also tried yoga on some of these patients. This also led to a lot of interesting encounters. There was an elderly gentleman who did not want to do yoga, even though we said it might benefit him. And then he would not give us a good reason as to why he couldn't do it. And eventually he revealed that he didn't want to do this because he did not have the tight yoga pants. And then we also did a lot of education, respiratory inhaler techniques, smoking cessation counseling, re-education about diet and nutrition. So everything you can think of at a usual rehab center, we tried to mimic that, and probably a little more because we were actually watching their home situation and trying to intervene on that as well. So these are some results. On the leftmost column is people who had no rehab, were hospitalized and then went with no rehab because either they couldn't sign up or didn't have facilities. These are historic controls, mind you. It's not a randomized trial. And then in the middle column is a small number of people who went to usual rehab. There's a long wait time to get to Spain rehab, so about 12 people, and this was data from 2015, 12 people went to Spain rehab within the first 30 days and got some exercise therapy. And then on the rightmost is we've reached about 53 patients so far. These are the first 50 patients who underwent the tele-rehab program. So you'll see that the characteristics are pretty comparable. But what I've highlighted in orange is that these patients in the tele-rehab program are actually sicker. They have worse FEV1, more people are in gold stage 3 and 4, and they also have a lower 6-minute walk distance. But when we compared their pre and post, we compared their FEV1 and all the parameters I'm going to describe on day 14 with day 90 when they came back. We found that their FEV1 improved. Again, not surprising because it was low when they had an exacerbation and they were recovering, and then at 90 days maybe they would have gotten better on their own. 6-minute walk distance improved considerably. Now the minimum clinically important difference is 26 meters, and this was way more than that, almost 3 times as much. There's a test we do to assess quadriceps strength and core muscle strength called the 30-second chair stand test. What you do is you set a timer and ask the patient to sit and stand, sit on a chair and then stand up and back sitting on a chair, and do it how many times they can. The minimum clinically important difference is 2, and we increase this by about 3.5. The San Diego Shortness of Breath Questionnaire, again this score ranges from 0 to 100, 100 being bad, 0 being great. The minimum clinically important difference is 5, and our patients improved this by almost 8 or 9. The MMRC is less sensitive to changes because it only ranges from 0 to 4. Again, this improved, but again was not statistically significant. The COPD assessment test is a symptom burden score ranging from 0 to 40, 40 being bad, 0 being good. The MCID is 2, and this score improved by almost 5. So great changes, but again, one could argue that these people were caught initially at the time of recovery from exacerbation. Maybe they would have improved to these extents on their own. It's possible, although these are benefits very comparable to usual pulmonary rehab. One more thing I didn't mention was we also did a psychosocial risk factor survey to look and see if rehab improves any of the other parameters. The total risk factor survey, which is more like a personality test, did not change, basically meaning you can exercise all you want, but it won't change your personality. Depression scores didn't change, anxiety scores didn't change, social isolation and anger and hostility, these are all subdomains of this score, none of those changed. But interestingly, right in the middle is guardedness. Guardedness considerably improved and was statistically significant. So this was interesting that people were more open with us at the end of the rehab program. But what was more interesting, like I said, all of these things could have changed on their own. But what was more interesting and more objective is the 30-day readmission rate. And this is, remember again, all-cause readmissions. With no rehab at UAB after our multidisciplinary interventions, again, these are historic controls from 2014, 2015, of the 80 patients with CMS, with Medicare, that year, 16% patients got readmitted within the first 30 days. And of people who went to remote rehab, 6%. This was 3 out of 50, of whom 1 actually got admitted due to C. diff diarrhea, nothing we could do about. A couple of them got readmitted for for COPD exacerbations. So this was a drastic drop in the readmission rates. And then this benefit persisted over 90 days while they were exercising. If you look at the readmission rates for 90 days, 16% got readmitted within the first 90 days compared to 28% for our historic controls. And then the attrition rate was low as well. Usual therapy, from our data from 1997 to 2012, when we look at that data, 50% people drop out of rehab every year. Whereas in this program, only 16% dropped out through the course of the program. Again, some of that credit has to go to Greg Sanders, who's here in the back. He pretty much chases every patient, first thing in the morning to last thing in the evening, so he's pretty persistent and dogged in his efforts. So what this has led to is now we're progressing on. So 2 years of grants ran out, and then the hospital was impressed by the results of this program, so we negotiated with them and finally got some extra funding to start a clinical telehealth program that will now cater to all patients in the state of Alabama. And this is not just for preventing hospital readmissions anymore, but anybody who has a need for pulmonary rehab, has COPD, but has no access to a rehab program can enroll in this program. We started out with COPD alone and are sticking to COPD because that's the one that's usually approved by insurance companies. Tele-rehab in Alabama is not approved by insurance companies, so none of this pays us anything. So what we want to do is stick to COPD, show that we can improve these patients and take the results to the insurance companies and try and convince them that this is actually a program worth investing in. It improves quality of life. So again, future directions, I spoke about some of the challenges with the devices. We're trying to come up with an integrated device that will do all the things that we need to do. We did talk to a biomedical engineering at the School of Electrical Engineering. He already had a device like that, but unfortunately you have to tie it around your ankle. So we said, no, that doesn't look good. It looks like you're in a prison. You're a prisoner, so we don't want to do that. So we're still working on it to try and get a better device you can wear on your wrist. Reimbursement is an issue. Alabama, unfortunately, does not have healthcare parity laws. So unlike some of the states, like even our neighboring Georgia, healthcare parity is not present in Alabama. So anything we do in the usual world, if we do it in the virtual world, should be reimbursed, but it's not in the state of Alabama. So we're still working on that. Also, we're doing some ongoing trials to look at the benefits and the mechanisms of benefit. We have a pilot study going on with muscle biopsies pre and post to see if the inflammation angle is actually true. So to conclude, we know that exercise and rehab work. Maybe if you start early, you can get more benefits. They also improve respiratory quality of life and reduce COPD readmissions. And maybe it's a proof of concept that aiming at extrapulmonary targets might be beneficial in a lung disease. Thank you.